Могу начинать, да? Good afternoon. The topic of our today's lecture is examination of the patient with respiratory system diseases. We'll come back to this topic because you didn't pass sub-module, and I won't stop on some basic questions which will be needed to you to pass sub-module first of all, and then exam of propedeutics. First of all, I want to remember you that respiratory system approximately may be divided on three parts. Respiratory tract, which includes trachea and bronchi, and as a result, inflammation of bronchus is called bronchitis. Specific pathology which manifested with attacks of bronchospasm is called bronchial asthma. Local dilation of bronchus due to anatomic defect is called bronchoectasis. If we are talking about lung, the inflammation is called pneumonia. Specific inflammation of the lung, which is caused by activity of Mycobacteria tuberculosis, is called tuberculosis. And lung abscess, which is specific destroyed inflamed pathology. У меня лекция в Ютубе, перезвоню позже. Which accompanied with formation cavity into the lung is called lung abscess. And canceromatous process is known for everybody. If we are talking about pathology of pleura, presence of gas in pleural cavity is called pneumothorax. Presence of liquid, hydrothorax. And during our today's lecture, we will example of this pathological process. If you see on the slide, you can see healthy respiratory system, which is characterized with empty bronchus, elastic lung, which main active units is alveoli, and thin pleura, which only covers the lung to hold them from other organs of the chest. Next slide, you see presence of liquid in pleural cavity, which is called hydrothorax. Presence of gas, pneumothorax. I want that you compare both this picture. In both cases, lung collapse, which is called compressive atelectasis, but in hydrothorax, lung collapse upward. In pneumothorax, lung collapse to the bronchial road. This patient more compensated than this patient. You can assess it depending on amount active lung tissue. If you see on this slide, you see that main bronchus closed, obstructed due to growth of tumor. As a result, because absent ventilation, lung tissue completely collapsed. We are talking about obstructive atelectasis. You see the density of the lung change. It becomes more density because no air. We are talking about airless tissue. This process is called pneumonia if it's caused by action of some bacterial agent, or if the alveoli is filled with blood due to obstruction of small vessels of pulmonary circulation, we can say about lung infarction. Focal consolidation of lung tissue. Focus of density of tissue is very small. We are talking about segmentary or lobular pneumonia. It may be initial stage of lung abscess, which you see on lower slide. It is final stage when the inflamed tissue destroyed due to activity of specific enzymes, Staphylococcus or Streptococcus invasion. As a result, after destruction will be formed cavity. Destroyed tissue will be removed through the communicated bronchus. Patient has specific unpleasant cough. If you see on this lung, this size enlarge, we are talking about emphysema or increased airness of the lung. On this slide, you can see formation of bronchoectasis, part of the bronchus dilated with formation specific dilated part, which may be filled with purulent contents in case of inflammation. We are talking about bronchoectasis, as this is lung after section of the patient with bronchoectasis. Now we can stop on main complaints of the patient with respiratory system diseases. First of all, each is dyspnea, difficult breathing, cough with blood expectoration or hemoptysis, and chest pain. There are 4 main complaints which are characteristic for pathology of respiratory system. If we are talking about cough, it is complicated refractory act, which is actually a defense reaction aimed at cleansing the larynx, trachea or bronchi from mucus or foreign material. Other words, when our patient complains of cough, doctor must find any substances which irritate bronchus to provoke protective reflex. Cough may be 2 types, dry or moist. And next, our question to the patient will be about types of the cough. If the cough non-effective, we are talking about dry cough. If effective with expectoration of sputum, we are talking about moist cough. Dry cough is characteristic for diseases which not accompanied with synthesis of mucus. It is laryngitis, tracheitis, other words, inflammation of upper respiratory tract. Dry cough is characteristic for the process which localizes outside of the lung and bronchus. For example, inflammation of pleura, dry pleurisy. And if the process localizes into the chest, for example, bronchus may be compressed by enlarged lymph nodes, patient with tuberculosis, patient with cancer or metastasis, or any other pathology. We must remember about specific pathology of the blood, lymphogranulomatosis, which starts from dry cough because pathological agent of this disease localizes into the chest and characterized with enlarged chest lymph nodes which irritate bronchus outside and accompanied with dry cough. Tuberculosis, lung abscess, acute bronchitis, and bronchogenic cancer can start from dry cough, but after some time, due to synthesis of mucus, it's transformed in moist cough. And some diseases of respiratory system can start from dry cough, later accompanied with moist cough. Condition of patient becomes better because respiratory tract cleansed with expectoration of sputum. Our patient with moist cough. Next question helps clear the doctor mechanism formation of moist cough. And first of all, we'll ask the patient about amount of expectorated sputum and clear when, during entire day or only in morning or to the evening. Because if the patient with chronic smoking bronchitis, for this group of patients, more characteristic morning cough. Then entire day, patient hasn't any subjective discomfort. Patient with lung abscess, cough will be provoked only due to definite position of the patient, and it is characterized with expectoration large amount of sputum. And we are obligatory ask the patient about character of the sputum, its color, odor, some visible specimens as blood, or sometimes patient can see small pieces of destroyed tissue. patient with morning cough. It's more characteristic for bronchiectasis, for lung abscess, for cavernous tuberculosis. If you remember our picture, you understand. Patient wants to sleep, he will sleep on affected side to hold pathological content into the cavity. Patient gets up, position change, and content of cavity removed through the communicated bronchus. And sometimes we'll use specific position of patient to intensify cleansing process. Patient complaints of the cough during entire day. It is characteristic for pneumonia and bronchitis because all inflamed period into the alveoli or into the affected bronchus will be synthesized any sputum to remove toxic substances, bacterial agent from the organism. And small amount of sputum irritate bronchus accompanied with cough. Patient with night cough, pay attention of doctor on the possible diseases such as tuberculosis and tumor, because in this process, in pathological process, oftenly involves vagus nerve, which activity increases during night period. Will obligatory ask the patient, cough is permanent or periodic. It also helps to clear some specific pathology. Cough with sputum, hemoptysis. Patient complains of hemoptysis. Doctor must find pathology which characterized with destructive process, because why blood into the sputum due to rupture of vessels? And to clear origin of hemoptysis, will obligatory ask the patient about characteristic of expectorated blood, its amount and character. Which is main diseases which accompanied with destruction and as result with hemoptysis? First of all, we'll exclude tuberculosis and canceromatous process. If no, we must remember about bronchiectasis, because delayed bronchus very easy ruptured patient with intensive coughing reflexes. We must remember about pulmonary infarction. I said you, when into the alveoli goes the blood from obstructed pulmonary vessels, and as a result, except sputum, patient will expectorate blood. And actinomycosis, inflammation of the respiratory system due to activity of fungus which grows through the tissue and vessel. I separate some other pathology which also manifested with hemoptysis but not caused by affection of respiratory tract. There are some heart diseases which complicated with congestion of blood in lesser circulation or thromboembolism of pulmonary artery. In thromboembolism will be formed lung infarction, about which we said. Patient with congestion of blood and lesser circulation expectorate blood, because blood absorbed into the alveoli because slow passage of blood through the vessels. We must obligatory clear amount of expectorated blood. Patient can say that blood expectorated as thin streaks. In this case, we can see about tuberculosis, actinomycosis, and heart diseases. Sputum may be completely colorated with blood. We are talking about the diffuse coloration of sputum, but it may be two types, jelly-like or foaming. Jelly-like sputum is characteristic for tumor, because together with blood, patient expectorates some pieces of destroyed tissue which very rich with protein and give specific jelly consistency. Foamy sputum, usually pink color, is characteristic for the patient with acute left ventricular heart failure, which manifested or complicated with lung edema. And sometimes patient can expectorate fresh blood which is characteristic for patient with cavernosus tuberculosis, with rupture of bronchoectasis, period of degrading tumor, and patient with pulmonary infarction. Sometimes sputum must be such rich with blood that patient can say, "You doctor, I expectorate fresh blood." We are talking about hemorrhage when the amount of blood deviates from 100 to 500 milliliters. We are talking about profuse hemorrhage when the amount expectorated blood exceeds half liter. Why is it significant? It's determined treatment tactic of the doctor, and you understand if hemoptysis patient expectorate small pieces of blood, we can stop bleeding with oral medication. In case of hemorrhage, bleeding sometimes can be stopped only after blood transfusion, and profuse hemorrhage needed only surgery treatment. Dyspnea is next often problem of the patient with lung diseases, especially patients with chronic lung diseases. We are talking about dyspnea when the patient feels any difficult of breathing. But we must remember, for the doctor, dyspnea, it is any changing of breathing, the rate, rhythm, and depth. Patient complaints of dyspnea, first of all, we must clear it is subjective, which not connected with pathology of respiratory system. Such type dyspnea is characteristic for patient with hysteria, thoracic radiculitis due to irritation of the nerve ending. And objective dyspnea, which appears due to true pathology of respiratory trunk and problem with gas changing. Next question which must be decided. Dyspnea is physiological or pathological? Physiological dyspnea. No, everybody after physical training feels fast and more deep breathing. But it's very fast disappears at rest. We are talking about physiological activation of respiratory system. Pathological dyspnea, not correlated with physical activity and cannot be released only at rest. Needed some medicamentouse correction. Next question about we must ask our patient. When patient feels difficult breathing during inspiration, we are talking about inspiratory dyspnea, expiration, expiratory dyspnea, or patient cannot clear both phase of breathing is difficult. We are talking about mixed dyspnea. Heavy dyspnea, which followed by asphyxia, is called suffocation. It may be result of acute left ventricular failure, lung edema, when the alveoli very fast filled with blood, no space for air, no impossible gas changing. For our today's lecture, we are talking about asphyxia, which appears due to spasm of bronchus. We are talking about bronchial asthma. In this case, patients suddenly sometimes feels a problem with expiration because through the narrowed bronchus, which constricted due to spasm, air easy moves inside and difficulty come back. It helps differentiate heart and lung problem. Patient with heart diseases feels problem with inspiration because alveoli filled with congested blood. Patient with bronchus diseases, bronchial asthma, feel problem with expiration, expiratory dyspnea. And last problem of the patient with respiratory system diseases is pain in the chest. But we must remember, To clear cause of chest pain, because into the chest except the lung present heart, present other organs, we must clear location of pain. We let the patient show side of the chest where does he feel pain. It helps clear its origin. Then we'll obligatory ask the patient about character of the pain and its intensity, severe, long, short, entire day, local, or spread other sides of the body. We are talking about irradiation. And obligatory will ask the patient about connection of pain with breathing, with cough, or with position. Because it helps differentiate any origin of pain. Problem with lung, problem with heart, problem with aorta, with muscles, with nerve ending, with subdiaphragm organs. If the chest pain is connected with pathology of respiratory tract, it may be only one cause, affection of pleura, because from anatomy you know, only pleura is rich with painful nerve ending. Lung and bronchus are free. It's explained why canceromatous process are revealed in final stage. Chest pain may be caused pathology of thoracic wall, ribs, nerves, and muscles. We remember about heart, aorta, and abdominal organs, which localizes under the diaphragm and innervated with same nerve ending as respiratory system. Pleural pain may be result of dry pleurisy or tumor metastasis into the pleura. Short time pain appears patient with pneumothorax, spontaneous, sudden rupture of the pleura. Short time of the pain. If the pain is caused by affection of thorax, first of all, we'll pay attention on skin, the trauma, specific inflammation as erysipelas or herpes zoster. We'll pay attention on muscles, its inflammation, myositis or trauma. We'll remember about inflammation of the intervertebral nerves, thoracic radiculitis, and affection of ribs, they fracture, inflammation perioditis, or specific immune systemic diseases, spondyloarthritis. Pathology of the heart, inflammation of the heart muscles, myocarditis, or its necrosis, myocardial infarction accompanied with severe chest pain. Problem with aorta, the aneurysm, local dilation, or inflammation, aortitis. And I said you about subdiaphragm organs, which is stomach, peptic ulcer, pancreas, acute pancreatitis, sometimes may be due to pathology of liver and gallbladder. But on the third course, we will differentiate only two groups of pain. Pleural, deep pain. У меня сейчас лекция, я перезвоню. Or superficial due to affection of thorax, and will stop on the differential diagnosis of these groups of pain. To differentiate, first of all, we'll touch painful areas. We'll use palpation and assess how patient responds on our palpation. Then we'll ask him deeply breathe and cough. Then we'll change position of the patient and pay attention when the condition of patient is better, when he sleeps on affected side or health side. We'll incline patient to affected side and again ask him about intensity of the pain. Patient with pleural pain, with pleurisy. Pain increases during deep breathing and coughing, and when the patient sleep on healthy side. Why? Because all these process irritate pleura due to intensive friction. Pleural pain decreases when the patient sleep on affected side or inclined to the affected side, because in this case activity of the pleural lace will be restricted. As a result, pain also will be decreased. Our patient with superficial pain due to affection of skin, ribs, muscles and nerves, first of all will respond on palpation, because will touch affected area, push on it, and pain intensify. Pain also intensifies during breathing and coughing, and when the patient sleep on affected side. I think you understand. Patient with fractured rib will never sleep on this side. Superficial pain diminish when the patient lies on the healthy side. If you attentively see on this slide, for differential diagnosis, we can exclude two problems, breathing and cough, because same result. And pay attention on response after our touching, on palpation, and position of the patient. If patient better feels when he sleep or inclined on affected side, and not response on palpation, which is deep pleural pain. Patient responses on palpation and sleep on healthy side, we find problem in chest structures. We said about main complaints which are specific for respiratory system, but pathology of respiratory system often accompanied with secondary complaints such as high fever, because fever is index any inflamed process. 80% of respiratory system diseases appears due to activity of microorganisms and accompanied with inflammation. And non-specific complaints such as weakness, decreased appetite, deranged sleep, decreased work capacity, which may be combined in group of common complaints or asthenic syndrome, because they characterized only activity of our life and never show any specific pathology. It show only gravity of diseases, and you understand, less problem patient with bronchitis than patient with pneumonia and tuberculosis. Next step of our examination is inspection. First of all, we'll start from common inspection. We'll assess common condition of the patient, and then we'll pay attention on specific sites of the body. For respiratory system, it is inspection of the chest. First, looking on the patient, we can see specific position. Patient with chronic respiratory diseases, especially patient with difficult breathing, will never sleep horizontally. We see that on his bed 2-3 pillows. Sometimes patient will be sitting position, and if the patient sits and press his extremities on any stand, knee, bed, table, we are talking about specific posture. Orthopnea, forced posture, which is characteristic for patients with attacks of bronchial asthma. We can see color of skin of the patient will be bluish, cyanosis, because blood overfilled with carbon dioxide. And we can see as patient breathe. If you see on yourself, our breathing in health condition invisible, we easy talk, eat, because we'll breathe through the nose. Patient with respiratory system diseases breathe through the mouth, and movements of the chest becomes visible. We can see movements of the nose and other accessory muscles. All these visible signs indicate about dysfunction of respiratory system or about lung failure. Compensated disease, invisible. We can see only signs of disease which when it becomes decompensated. Examination of the chest must be made with definite order, and I'll pay your attention on the plan of the chest examination. First of all, we'll distinguish two types of chest examination. Static, usual breathing of patient. We'll pay attention only on shape of chest, and you understand conclusion of our static examination will be about shape of the chest. Dynamic examination will give characteristic of breathing, and our conclusion will be about character of breathing. Static examination. First of all, we'll compare right and left side of the chest, assess its symmetry. Then our examination will be from up to down, from front to the back. It is usual way of any examination. From up to down, from front to the back. We'll pay attention on position of claviculas, expression of supra and subclavicular fossa, direction of ribs, width of intercostal space, and only after that we'll assess epigastric angle. It's your main mistake on exam. You remember only about epigastric angle. Are all preceded information you lost. Then we'll turn our patient and pay attention on position of the shoulder bladders and direction of spine. If you see on this picture again, first of all we'll compare right and left side, expression of supra and subclavicular fossa, direction of rib along lateral side, width interspace, then epigastric angle, patient turn. We'll pay attention on position of scapula and direction of spinal cord. Let's see how will be formulated our answer depending on shape of the chest. First of all, we'll distinguish two types of the shape: physiological or normal and pathological. Physiological chest depends from constitution of the patient, normosthenic, hypersthenic, and asthenic, but order determination is different. For the constitution, we'll pay attention on the whole body. And first of all, compare size of the chest with size of abdomen. When we'll determine shape of the chest, we'll pay attention only on chest characteristic. Pathological shape of the chest. We distinguish 5 types of pathological chest. Emphysematous, which is characteristic only for one disease, emphysema. Paralytic, rachitic or pigeon chest, funnel, and foveated. Physiological chest. Our patient with normosthenic constitution. Let's give its characteristic. First of all, chest is symmetrical. Supraclavicular fossa visible. Subclavicular fossa invisible. Ribs has inclined direction. Interspace between 1.5 to centimeters. Epigastric angle nearest 90 degree. Shoulder slightly separated from the chest. Spinal cord has physiological deviation. Asthenic chest, also symmetrical, but significantly pronounced supra and visible subclavicular fossa. Rib has more vertical direction. Interspace more than 2 centimeters, slightly widening. Epigastric angle less than 90 degree. Scapula separated from the chest as wings of the bird. Spinal cord has physiological direction. Hypersthenic constitution. Chest also symmetrical, but supra and subclavicular fossa invisible. Rib has slightly horizontal direction, interspace narrow width, nearest 1.5 centimeters or slightly less, epigastric angle more than 90 degrees, scapula invisible because tightly pressed to the chest, spinal cord has physiological deviation. Let's see on our patient. Patient with nomoscenic constitution because chest is symmetrical. We see only supraclavicular fossa, rib slightly inclined with medium interface, epigastric angle near 90 degrees, scapula slightly separated from the chest. Hyposcenic constitution. No supra and subclavicular fossa, rib slightly horizontal and narrow with interface, epigastric angle more than 90 degrees, scapula invisible because tightly placed to the chest. Ascenic constitution. You see supra and subclavicular fossa, easy visible ribs which has slightly vertical direction with wide interspace, epigastric angle sharp less than 90 degrees, scapula separated from the chest and easy seen spinal cord, but we see slight deviation to lateral side and slight asymmetry of the scapula because our patient with scoliosis. Pathological chest may be formed due to deformation, patient with tuberculosis of the bone. It may be formed after trauma or may be specific chest, emphysematous chest, which is characteristic for patient with emphysema. Slightly resembles hyposcenic constitution, but on contrary from them, it has both vertical and transverse size approximately same, and chest resembles barrel. Its other name is barrel-like chest. Let's compare. If you remember hyposcenic constitution, slightly narrow with interspace, epigastric angle slightly more than 90 degrees, barrel-like shape of the chest. In hyposcenic chest, supra and subclavicular fossas are invisible. In this case, they protruded. Rib has horizontal direction but interspace widened and intercostal muscles protruded. Epigastric angles becomes flat near 180 degrees. You see patient with hyposcenic constitution and patient with emphysematous chest, protrusion of supraclavicular fossa, and chest resembles barrel because it's dilated in both transverse and anterior posterior sides. Paralytic chest, first of all, resembles ascenic but more significantly visible supra and subclavicular fossa, no subcutaneous fat tissue because prolonged severe diseases, tumor or tuberculosis. Pidgeot-like chest, characterized with protrusion of the sternum. This chest is from patient with rachitis and it is called as a rachitic chest. You see patient with funnel chest, which is characterized with depression of the sternum in its lower part, near its xiphoid process. It is characteristic for the patient with shoemaker profession, foveated chest. And on this picture, you can compare physiological nomoscenic chest, emphysematous chest, foveated chest, and Pidgeot-like chest. We'll pay attention on position of the spine. Normally, it has 4 curvature. It's assessed in vertical position of the patient and obligatory will palpate spinal cord and pay attention on line. Physiologically, we distinguish 2 anterior and 2 posterior deviation. In pathology, deformation of the spine may be caused by the lateral curvature, which is called scoliosis, which is formed of the patient in younger period, usually childhood period, due to incorrect position. Backward curvature of the spine, kyphosis, usually is result of any specific pathology. Significant deformation is called gibbous. Forward curvature of the spine, lordosis. Sometimes we'll see combined deviation. For example, lateral and back. We are talking about kyphoscoliosis. Lateral scoliosis, backward kyphosis, upward lordosis, combined deformation and significant protrusion of the chest is called gibbous. You see physiological position, you see pathological lordosis, pathological scoliosis, formation of gibbous, lordosis with gibbous, also each is kyphosis or each is gibbous. You see patient with gibbous due to significant deformation, backward deformation of the chest. Patient with scoliosis, insignificant and more significant when we visually see asymmetrical position of the scapula and significant deformation of the chest. No, there are women with tuberculosis of the bone, which complicated with specific deformation of the chest. When we said about symmetry of the chest, compares right and left side. In case of asymmetry, we can say about enlargement or diminish one part of the chest. Chest enlarge. Patient with hydra and pneumothorax. Chest diminish due to pleural adhesion, pneumosclerosis, or rejection of the part of the lung, or its collapse, atelectasis. Pleural adhesion and pneumosclerosis, diseases which accompanied of the growth connective tissue, which diminish size of the normal tissue. You see patient with hydrathorax, asymmetric enlargement, pneumothorax, asymmetric enlargement, adhesion of the pleura, asymmetric diminish, and obstructive atelectasis, also asymmetric diminish. Health people with symmetric chest, patient with asymmetric diminish because local atelectasis, patient with asymmetric protrusion because hydrathorax. Dynamic examination of the chest. Give characteristic about breathing, and first of all we'll assess type of breathing. Then its rhythm and count rate. Why rate after rhythm? Because if the rhythmical breathing, we can count rate during short time. If arrhythmical, only during whole minute. And depth of breathing with assessment symmetrical movements of the shoulder during breathing. It is plan of dynamic examination of the chest. Type of the breathing depends from the part of the body which more actively movable during breathing. If chest, we are talking about thoracic, which is more characteristic for female. If abdomen, abdominal, which is characteristic for the man. If whole body actively movable, we are talking about mixed type of breathing, which is characteristic for people with some pathology. And you understand, if mixed breathing was revealed in female, will find problem into the chest, because due to restriction of chest activity, abdomen actively involved in pathological process. If our patient is man with mixed breathing, will find problem into the abdomen, which restrict activity of diaphragm and provoke more active movements of the chest and formation mixed breathing. Respiratory rate will count when the patient are unknown about our action, because if the patient oriented, he can artificially intensify breathing or accelerate pulse. Will simulate counting of pulse, and then put our hand on the part of the body which more characteristic for our patient. Our patient is woman with thoracic part type of the breathing. Will put hand on the chest and simulate pulse. Will calculate movements of the chest. Normally, respiratory rate varies from 16 to 20 per minute. If lower, we are talking about bradypnea. If more, tachypnea. Breathing absent, we are talking about apnea, which is called accelerated respiration. It may be physiological or pathological. We are talking about physiological tachypnea. After physical exercise, sometimes it may be patient with emotional excitation or after eating, especially after heavy meals. Pathological tachypnea appears to compensate gas changing. Other words, patient accelerate breathing in case when the respiratory volume, amount of inhaled air decreases. It may be caused by decreased elasticity of the lung, restricted expansion of the lung, patient with emphysema. It may be caused narrowing of the small bronchus, bronchiolitis, which more characteristic for children. It may be a result of affection of the pulmonary tissue, the inflammation, pneumonia, the compression, atelectasis. Accelerated respiration may be when the patient cannot adequately inhale due to outside obstruction, inflammation of pleura, which restrict activity of the lung, inflammation of chest muscles, inflammation of chest nerve, and fracture of ribs. Short-time tachypnea may be characteristic for the people with ascites, liquid into the abdomen, meteorism, gas into the large intestine, which accompanied with rising diaphragm and restriction of the lung activity, and for pregnant women. Patient with adhesive pleurisy, right lung expansion restricted. It will be compensated with more fast-breathing tachypnea. Lobe pneumonia, no space for adequate breathing. Again, patient will compensate with rate. Hydrothorax, decreased active surface of the lung. Obstructed atelectasis, only 1.5 lung can breathe. Compensated with tachypnea. Pneumothorax and emphysema, lung overfilled with air but no elasticity, no adequate gas changing. Organism feels deficient of oxygen, compensation with rate. Deceleration of respiratory rate also may be physiological and pathological. Patients slowly breathe during sleeping, and some trained patients can breathe slowly because high elasticity of the lung. Pathological bradypnea is caused by, first of all, depression of the bone marrow, toxic effect on respiratory center, patient with kidney and liver insufficiency, patient with diabetic coma or any infectious diseases. Pathological bradypnea may be due to true pathology of the central nervous system. We are talking about inhibition of the respiratory center, patient with increased intracranial pressure, growth of tumor, inflammation of brain, meningitis, brain stroke, cerebral hemorrhage, or brain edema. We'll assess depth of breathing. Normally, our breathing with moderate depth and usually in usual condition unvisible. But sometimes movements of chest such insignificant that needed more attention from the doctor to decide patient live or die. We are talking about superficial or shallow breathing. Opposite. Breathing is seen on distance, deep breathing. Superficial breathing accompanied with tachypnea because depth and rate mechanism which compensate our breathing act. Superficial breathing may be accompanied with bradypnea in case of inhibition of respiratory center or significant and sharp narrowing of vocal slit or trachea. Deep breathing, accompanied with tachypnea in case of high fever and anemia to compensate hypoxia, and deep breathing accompanied with bradypnea, pathological bradypnea, in some comatose stage of the patient. You see normal breathing, normal medium depth, and normal rate. Pathological depth, Kussmaul respiration, which is characteristic for some comatose stage. You see patient breathes slowly and deeply. Other characteristic of Kussmaul respiration is loud, which is audible on significant distance, and we see as patient trunk actively move. Respiratory rhythm. Normally, our rhythm is regular. We'll breathe through the definite intervals. In pathology, we can reveal some arrhythmic breathing. Biot respiration. Patient breathes with short pauses, which is characteristic for inflammation of the brain or disordered cerebral circulation, and last time of patient life. We are talking about agony, short time before death. Breathing with short pauses. Chain stalk respiration, when will be change not only rhythm but depth also. You see patient breathe superficially, then depth increases, decreases, and stop, and again process repeated. Chain stalk respiration is characteristic for the patient with disordered cerebral circulation after any poisoning, and for specific disease, Pickwick syndrome, patient with obesity and progressive atherosclerosis of the cerebral vessels. Undulant Groker respiration resembles chain stalks, but patient breathes without pauses. will change only depth of breathing for shallow to deep and again diminish, intensify, diminish, like wave. This breathing is characteristic for any pathological process and maybe early stage which preceded or appears after change stroke respiration. Any arrhythmic breathing indicates about gravity of disease and often appears before death of patient. And last question on which I want to stop today, which is projection of the lung on the chest. Question which had lot of problem on exam. But doctor must be oriented about projection of upper, lower and medium lobe of the lung to give some direction for next examination. For example, upper or lower lobe pneumonia and any other pathological process. To say about lung projection, we'll artificially cut our patient through the sternum and unroll him. Each is one part of the sternum, other part of the sternum, and spinal cord. Our patient's life. We needed two projective lines, linea axillaris anterior and posterior, and we see anterior part, lateral, posterior, again lateral and anterior. Projection will start from building of main interlobular line. First dots will put on the level third chest vertebra. У меня лекция, я перезвоню. Then we'll find fourth rib on the linea axillaris posterior, sixth rib on the linea axillaris anterior, and find its interconnection with chest. When we'll interconnect all these dots from third chest vertebra to junction of sixth rib with sternum, we'll have main interlobular line. Same order to the left. Third chest vertebra, fourth and sixth rib. This main interlobular line divides our lung on two parts, upper and lower. But right lung has three lobes, and we must build secondary interlobular line, which started from fourth rib. We'll interconnect fourth rib on the linea axillaris posterior with its junction with sternum. As a result, our right lung divided on three lobes. Above fourth rib, upper lobe. Between fourth and sixth rib, medium lobe. And below sixth rib, lower lobe. And you see that pathology of the upper lung lobe we can reveal in front, because small part projected lateral side and at the back it's covered with scapula, because level of scapula 7 rib. Pathological process in lower lobe better find at the back, below the scapula and lateral side, because you finish to study topographic lung percussion and you know that lower level of the lung along linea axillaris anterior along 7th rib. No, 1 inch space insignificant for diagnosis process. And medium lobe pathology will find anterior and lateral surface between 4th and 6th ribs. If you compare our picture with position of the lung, you can see that upper and lower lobe. Upper lobe diagnosis in front, lower lobe diagnosis at the back. That's all today. Thank you so much for your attention, and we'll meet with you through the week.